All right, next is discussion on osteomyelitis by Dr. Robert Frykberg.
Morning, everybody. It's a pleasure to be back at the new and improved TED meeting. I'm going to be focusing primarily on diabetic foot osteomyelitis. These are my disclosures. I have no conflicts of interest otherwise for this talk. We know that there's a number of very important lower extremity complications of diabetes mellitus. PAD is just one, but a growing problem in not just in this country, but around the world. And we're going to be talking about the other ever-present problem in diabetic foot infections, and specifically osteomyelitis, all in 10 minutes. As Mark said, it's a little difficult to challenge on this. I've used this graph for many years. It just indicates the complexities and the underlying metabolic perturbations present in many diabetic feet, composed of neuropathy, not just sensory, but autonomic and motor neuropathy. Vascular disease is not just macrovascular disease. We also have to keep in mind the important role of microvascular disease and a growing interest in small artery disease and MAC disease, medial arterial calcification disease. All of these complexities coalesce into that high-risk foot that becomes susceptible to infection when the skin envelope is interrupted, as you well know, developing infection, gangrene, etc., leading to amputation. So not every patient is this complex, but we have to recognize that many of these underlying metabolic problems are present in most of our diabetic patients in the lower extremities. So let's talk about osteomyelitis, and my talk, luckily, is just focused on diagnosis. It's impossible to talk about osteomyelitis in 10 minutes. But we know that osteomyelitis complicates the diabetic foot in about 16 to 20% of diabetic foot lesions. This is just based on prior literature. And most frequently, it's not appreciated on clinical exam because you're not looking for it. If you look for it, you're going to find it, and especially in long-standing, deeper, larger ulcers. Generally requires surgical debridement, and that was my mantra practicing in Boston many years ago, but there's more data to suggest that a minor forefoot osteomyelitis can be treated medically alone if there's not severe soft tissue infection with it as well. We recognize that recurrences are always common because of inadequate primary treatment, so we need to keep these factors in mind. I think diabetic foot osteomyelitis is different than osteomyelitis of long bones in the non-diabetic patients. It's got, because of neuropathy, peripheral arterial disease, and immune compromise, it makes it a little bit more difficult in this regard. I need to focus on literature here. The International Working Group of the Diabetic Foot just met in May, and they every 4 years they meet and upgrade the International Working Group guidelines. And I'm just referring you to these. I can't go through all the guidelines, but on focusing on the 25 total recommendations for soft tissue and bone infections, there are several specifically focused on osteomyelitis. And they're recommending the combination of a probe-to-bone test, plain x-rays, ESR or CRP, or even procalcitonin to make your initial diagnosis. Usually a high degree of, or a high index of suspicion with a probe-to-bone test. For me, that at least raises my index of suspicion, and then I'll go deeper and further, always leading to perhaps an MRI if necessary to identify the extent of the lesion. And of course, the definitive diagnosis always has to be made on bone biopsy and culture. Any paper that reports incidence and prevalence of osteomyelitis without making the definitive diagnosis, and there have been many, you can't rely on those diagnoses. We recognize there are many possible radiographic clues that indicate osteomyelitis, most importantly, of course, cortical erosions, osteolysis, sinuses leading to the bone and a long-standing ulcer. Direct exposure of bone, probing to bone, to me, has always been the leading indicator, for, in my mind at least, for osteomyelitis. And you all have had experience with various different presentations. But remember, it's always x-ray first. And if you can see these subtle changes on an x-ray in the appropriate patient with most likely a probing to bone, you can pretty much establish your diagnosis there. So practicing and training in Boston, the infamous Grayson paper from March of 1995 yielded an 89% positive predictive value for a positive probe to bone test. I still rely on that. Those of you who have trained with me know that I always had some sticks in my pocket to probe to every bone, every wound, because if you look for it, you will find it. And you need to find it because this is one of the major reasons for recalcitrance of these long-standing diabetic foot ulcers, reasons why they don't heal or why they blow out after they have healed because of lingering infection. So always get comfortable with probing to bone. One thing we haven't used, although we were toying with it when I was still at the VA, is ultrasound diagnosis. Now, this paper was just published by my colleagues in Madrid, Spain, looking at the diagnostic performance of ultrasonography in patients with suspected osteomyelitis. They used probe to bone tests, they used x-rays, but specifically they were looking at ultrasound diagnosis as the primary mechanism and comparing it to bone culture and histopathology. And they found 24 out of their 47 patients were diagnosed with diabetic foot osteomyelitis. And they had a power Doppler. Now, power Doppler is a color Doppler, so I don't have a good image of it, although there is one on the bottom right here. But what they found is that cortical disruption was present in 96% of patients with diabetic foot osteomyelitis. And the positive power Doppler was present in 100% of those with confirmed osteomyelitis. So I point you to the bottom images where you can see periosteal reaction with sclerosis, cortical erosion, which is the classic finding on ultrasound, especially contiguous with an ulcer, separation of devitalized bone like sequestrum, and then on the right bottom image, there should be a color Doppler where you see blood flow in an area of sclerotic bone or inflamed bone. So this is a brand new paper, hot off the presses, but it's something to consider that you can use ultrasound as a point of care diagnostic modality, especially for those chronic wounds. So in summary, we always need to have a high index of suspicion, especially in long-standing ulcers, those with bone exposure, those with probe to bone, and also not alone, but in concert with x-rays and probe to bone tests, elevated ESR, CRP, or procalcitonin. Again, x-ray first, always, always. And if you have classic changes on x-ray, contiguous with an ulcer, you've made your diagnosis, especially in the presence of these other clinical findings. The problem and the difficulty is when x-rays ostensibly are normal, which can often be, because remember, x-rays are just two-dimensional, not three-dimensional. So if you have a plantar ulcer that probes to bone and you take an AP x-ray or a lateral x-ray, you're not going to likely see any bone changes. So in that case, you need to move to advanced imaging as the International Working Group guidelines and the IDSA have recommended. Then you would go to your MRI, of course, your CT, your PET, your MRI PET, what have you, or SPECT imaging, whatever you have available to help make that and confirm that diagnosis. And also, I want to raise the important point, use your ultrasound. You know, most of you are much better at using ultrasound than I am. But ultrasound now is becoming a recognized point-of-care modality to make that initial diagnosis of clinical osteomyelitis. And then, of course, no diagnosis of osteomyelitis is complete without getting that bone biopsy, even if it's a percutaneous bone biopsy adjacent to an ulcer, and culture. Bone biopsy for histological changes and culture so that you know what you're treating. Most osteomyelitis in the diabetic foot are usually from one pathogen, and if staph is in that culture, it's more likely than not going to be typical Staph aureus. So isolate the pathogen, of course. And with that, 10 minutes, you have a complete primer on diabetic foot osteomyelitis diagnosis. Thank you.
Thank you.